Thank you very much. Thank you to the organizers. Assalamu alaikum, everyone. So I've been tasked with this difficult topic of how to approach autoimmune serological disease. And to make it even more difficult, I'm the last speaker that's holding you from lunch. So I'm going to try to keep it as simple as possible. So I've often seen medical physicians struggling with this topic, and often we end up with patients with lots of positive serology and we don't really know what to do. So as the theme from this morning is coming is clinical context is extremely important, and that is true for these autoimmune rheumatic tests as well. So my learning objectives is that I'm going to talk about the commonly used serological tests. We're going to see how we can interpret it in the clinical context, and we also need to be aware of the diagnostic utility and the limitations of these tests. So why is this important? Why I'm talking to you as internal medicine physicians? Well, the rheumatology presentation can be to any specialty, and many of the times these patients can present to you before they come to us as rheumatologists. The symptoms can be quite non-specific at the beginning, but at the same time, it's very important to recognize these conditions, as we know that early referral to rheumatology, early treatment can prevent both joint as well as organ damage. So I want you now to think about the last time or the most recent time that you tested a patient for any rheumatology serology. So can anyone shout out why they did the test? So what was what did you want to know? The diagnosis, or were you doing screening or monitoring? Diagnosis, screening, acute. Okay, so in the rheumatology world, these are the 5 indications why we would do any rheumatology test. So screening a disease, diagnosing a disease, whether we need to monitor the disease, see whether our treatment is working, to identify some end organ involvement, and also to check the response to treatment and to see the drugs that we are giving, whether they are safe to continue with the patient. If you don't have these indications, the bottom line is that you don't do the tests. So let's put this in practice. So this is, I'm going to discuss a few cases. So this is a 23-year-old student. She's got a 2-month history of feeling tired. She's got pain in her muscles, which is mainly the back of her neck and her upper arms. There is no history of any joint pains, and her symptoms on the whole are worse in the morning. Systemic inquiry is unremarkable. So in this patient, would you do any autoimmune rheumatology tests? And if you do, what tests would you do? I want you to think about this. The next patient is a 45-year-old lady. This lady is also feeling tired, but she's also got pain in her joints. You can see there are the smaller joints of the hands, wrists, ankles, so both upper limb, lower limb. She's also got some swelling in the smaller joints of her hands, and she's feeling stiff in the morning. So in this patient, would you do any autoimmune rheumatic tests? And if so, which tests would you do? Now let's go to the ward. So this is a patient who's admitted under your care. He's known to have rheumatoid arthritis. He's been on methotrexate 20 milligram once per week. He's had a pneumonia. While you were treating the pneumonia, you stopped the methotrexate on the discretion of the rheumatologist on call. The patient has now recovered from pneumonia, and you are now planning to discharge the patient. And the patient asks you, he says, "Doctor, I want you to check whether I can stop my medication, whether I can stop my methotrexate, because my symptoms have been fine. I've not even used an anti-inflammatory. So are there any tests that you can do to tell me whether I can stop my methotrexate for rheumatoid arthritis?" So in this case, are there any tests that you can do? Okay, so now we're going to talk about there are lots and lots of rheumatology diseases, and these can be quite confusing to you as internal medicine physicians. So we've got the big group of rheumatoid arthritis, we've got the seronegative inflammatory arthritis, and then we've got these confusing connective tissue diseases with difficult names, and then the ANCA vasculitis. And we've got lots and lots of autoantibodies as well. So this can all be quite daunting to you as internal medicine physicians, and there must be a way of how we can link them together so that you can test the right patient for the right test and know how to interpret it. So the first question that you want to ask is, does this patient really have an autoimmune inflammatory rheumatic disease? Because if that's not the case, there is no point in doing these tests. So the first symptom, or the most common symptom that these patients present with, is musculoskeletal pain. So if this patient has musculoskeletal pain, the most important question is the pain due to inflammation or is the pain due to mechanical reason? Because the diagnosis is completely different. The tests that you're going to do are completely different. And if the patient does have inflammatory joint pain, the next question is it rheumatoid arthritis? Is it connective tissue disease? Are we dealing with a vasculitis? Is it seronegative? Is there any spinal involvement? You've probably seen this slide quite a lot of times, the difference between inflammatory pain and non-inflammatory pain, but I cannot emphasize enough, and this is the most important question that we as trained rheumatologists still ask when we're seeing the patient for the first time in the clinic. Is the pain due to an inflammatory rheumatic disease, or is the pain due to a mechanical reason? Because that's going to change the whole course of how you're going to test this patient and how you're going to treat the patient. So on the whole, the inflammatory pain is better with exercise, it's worse with rest, and these patients tend to be stiff. Now in the textbooks, it always says you need to be stiff for about 30 minutes in the morning. You don't always have to be 30 minutes, but in general, if the patients are stiffer in the morning compared to the rest of the day, they usually have inflammatory pain. And then you can have the other symptoms of swelling, warmth, and any signs of inflammation. So once you've established that this patient has got inflammatory joint symptoms, then the next question is, does this patient have rheumatoid arthritis? Because rheumatoid arthritis is quite common. The prevalence is about 1%. And what are the features that will make you think about rheumatoid arthritis? I mean, the other speakers have talked about this already, but just to give you a summary, in rheumatoid arthritis, the symptoms tend to be symmetric. If it's on one side, it tends to be on the other side as well. And the other thing is that you have small joint involvement, so usually the hands and the feet. These patients can also have systemic symptoms, but the other point I would like to highlight is patients with rheumatoid arthritis, they're not silent. When they develop rheumatoid arthritis, it tends to be progressive. So if a patient comes to you in the medical clinic and says, oh, I've got rheumatoid arthritis for 10 years, but I didn't need any treatment and my joints are fine, it's not usually rheumatoid arthritis, because rheumatoid arthritis by its nature is a progressive disease. So if you suspect rheumatoid arthritis, you need to do the serology specific for rheumatoid arthritis, and I will talk about that later in the talk. Now, the next question is, if it's not rheumatoid arthritis, is it connective tissue disease? So what are the clues that will make you think about the fact that this patient may have a connective tissue disease? So in addition to joint symptoms, the other things that you would like to look for or ask for about the patient is, does this patient have any myalgia or muscle pain? Are the symptoms of photosensitivity? Does the patient have dry eyes, dry mouth, Raynaud's, mouth ulcers? Is there a history of serositis? Maybe the patient had a history of pleurisy or pericarditis in the past. If you find the constellation of these symptoms, you would think more about connective tissue disease rather than rheumatoid arthritis, and in that case, you would be doing the serology specific for connective tissue disease, and I'm going to talk about that later. The other clues that you can get when you do your usual test is abnormalities on the CBC. For example, the patient can have a low white cell count, low platelets, there may be evidence of hemolytic anemia, or there may be abnormalities of renal function tests. In general, if patients have abnormalities on renal function tests, they have joint pains, and they have some rashes, it's usually connective tissue disease or vasculitis. So then you should be thinking about the serology specific to this condition. Then I've taken out the vasculitis because that's a big topic on its own, and I think the time today doesn't permit that. So the next diagnosis you should be thinking about is this patient has a seronegative inflammatory arthritis or spondylitis, and in that case, you also think about inflammatory spinal involvement, because that's also part and parcel of a seronegative inflammatory spondylitis. So the features to look for would be musculoskeletal symptoms apart from the joints. For example, this patient may have inflammatory back pain, the patient may have tendon involvement, so they may have Achilles tendonitis, or they may have a history of tennis elbow or golfer's elbow, or a history of shoulder tendonitis or frozen shoulder in the past. So it's important to ask for these symptoms. And the other extra-articular features would be symptoms of inflammatory bowel disease, skin psoriasis, or uveitis. And a personal history is important, but also a family history of any of these features can help you to get to these diagnoses. So again, if you're suspecting this group, there are specific tests that you would do for this group. So moving on, before, again, you order any serological rheumatology test or any test in general in medicine, you also need to be aware of the other features of the test, like what's the sensitivity of the test, how specific it is, and accordingly, what's the positive and the negative predictive value. So in general, a test which has a high sensitivity, it's not usually very good for the diagnosis, it's good for screening. And its usefulness is usually in excluding a diagnosis, and it's significant if it's negative, because if it's negative, you can kind of say this patient doesn't have this disease. And a prototype of this test is an ANA, which is very, very commonly ordered by the internal medicine physician. So it's a test for screening, but not for diagnosis. Talking about specificity, a test with a high specificity is important for diagnosing a condition, but it may not be present in all the patients, and it is significant if it is positive. So an example of this test would be, for example, an anti-Smith antibody for lupus, or for example, an anti-CCP antibody for rheumatoid arthritis. So let's talk about a few of the top common tests that you guys do. So an anti-nuclear antibody, it is a very common serological test, and I've explained already, it's a test with a high sensitivity, but it's not very specific. It is present in many of the rheumatology conditions, for example, lupus, the other connective tissue diseases, for example, scleroderma, Sjogren's syndrome, mixed connective tissue disease, and about a fourth of the patients with rheumatoid arthritis can also have a positive ANA. So once you have a positive ANA, you're thinking about all these conditions, and then the clinical picture will help you to put the patient in the specific box, not the ANA test, the clinical picture. But you also need to remember that the positive ANA can be present in 25% of the normal population, particularly females, particularly as patient gets older, and also in patients of African and American origin. Some other facts about ANA is that it's also important to know that the hospital that you're working in, or the lab that you're sending your test to, what technique are they using to do the ANA test? Because there are different techniques. You've got the immunofluorescence, which is the gold standard, but nowadays, a lot of the labs are using the ELISA technique, which is a more automated technique. So if you're suspecting a patient to be ANA positive and it's coming out negative, then you should question the lab what tests they are doing, what kit they are using. If they're using immunofluorescence, you may want to ask them to do an ELISA in addition as well to see whether that can increase the yield of getting a positive test. Also, if you suddenly start getting a lot of positive tests or a lot of negative tests, you need to pick up the phone and find out whether your lab has suddenly changed the method by which they are doing the ANA test, because it's very much dependent on that as well. Some other facts about ANA test is that I've already mentioned it's a high sensitive but a low specific test. Not only you get a positive and negative, but you also get some quantification, like it can be positive from 1 in 40 to 1 in 640. When 1 in 40, it doesn't usually alert us as rheumatologists, but when it becomes to 1 in 80, that's when we start thinking about autoimmune rheumatology tests, and 1 in 160 is actually quite significant. And it's one of the diagnostic criteria to diagnose lupus. So in addition to rheumatology diseases, there are many other diseases that you as internal medicine physicians see which can cause a positive ANA test, particularly chronic infections. I often get called to the ward where a patient with suspected TB has got PUO, enlarged lymph nodes, a bit of polyarthralgia, someone decides to do a positive ANA, bang, it's positive, and they say, oh, please come and see this patient. We think this patient has got Still's disease, but it turns out that he's got TB or a viral infection. So it's important to be aware of all these other associations of a positive ANA as well. So ANA is most useful when it's negative because it almost excludes the presence of certain rheumatology diseases, particularly lupus. When it is positive, you should also be thinking about the non-rheumatological associations. You should always check the titer. and then you should decide to do further testing if the patient has the clinical features that I've already described before at the beginning of the talk. Moving on to the lupus antibodies, lupus is characterized by lots and lots of antibodies. So in addition to an ANA, you can get a dsDNA, and you can also get a Smith antibody. The dsDNA is quite specific for lupus with a specificity of 95%. The level also fluctuates with the disease activity, so it can be used to monitor the disease activity. And often we find that as the patient is flaring, the dsDNA levels can actually rise. So rising dsDNA levels means that the disease is active. The anti-Smith antibody, it's not present in all of the patients, only 20% of lupus patients, but when it is present, it's very specific. We don't have such a specific test in rheumatology apart from this anti-Smith antibody. So if you've got anti-Smith antibody, always think about lupus. However, it doesn't correlate with the disease activity or any specific organ involvement. Complement levels, again, a test that's very commonly used in patients with lupus. If you don't suspect lupus, don't do complement levels because that's not going to give you any information. Only do in a patient with lupus. And in patients with lupus, low complement levels indicate disease activity. Now is this big confusing group of the ENA antibodies, and these are the 8 common ENA antibodies. However, most of the labs only check the top 6, the ROLA, Smith, U1RMP, the anti-SCL70 centromere, but some of the labs also check the Jo1 and the MI2 when you ask for the ENA antibodies. So what these antibodies mean? So these are usually associated with connective tissue diseases, and you should also only do them if your ANA is positive or you find these features. For example, this is a patient with myositis with proximal myopathy. You can get a Jo1 or MI2 positive, or a patient with Raynaud's, you're suspecting maybe scleroderma or Sjogren's syndrome, or a patient with lupus with a malar rash, the mouth ulcers, the alopecia, or if you're suspecting Sjogren's syndrome with the dry eyes and the dry mouth. So the clinical features should prompt you to do these ANA antibodies. So these ANA antibodies, you don't get a quantification, you only get whether it is positive or negative, and some of the labs report it as weakly positive. They are helpful to identify the specific connective tissue disease, whether it's Sjogren's or it's scleroderma. But it's important to remember that all these connective tissue diseases, they are kind of like brothers and sisters of the same umbrella, come under the umbrella of connective tissue diseases. And they share some of the common clinical features, but they also share the autoantibodies as well. So a patient with scleroderma can also have a Rho antibody, or a patient with lupus can also have a U1RNP antibody. So don't be too much confused about the autoantibody profile. You should diagnose the disease on the basis mainly of the clinical features or maybe of the organ involvement rather than the specific serology. However, there are different autoantibodies which are described with different diseases, as I've mentioned in this table. So moving on, some of the autoantibodies are linked with a specific organ involvement. For example, if you have a patient with anti-centromere antibody, you should be thinking about and screening for pulmonary hypertension. If you've got anti-SCL antibody, you should always be checking their skin disease. And Jo1 antibody, in the context of myositis, is linked with interstitial lung disease. So if you see these patients in your internal medicine clinics, you should be consulting the pulmonologist as well to screen for and to monitor for interstitial lung disease. So ROLA antibodies, these are important for you to know because if a patient has these ROLA antibodies and they become pregnant, they need to be referred to the obstetric team or the medical obstetric team because these antibodies can cross the placenta and they can cause neonatal lupus with congenital heart blocks as well as rashes as described in this picture. And these antibodies are present in patients with Sjogren's syndrome, but also in patients with subcutaneous lupus as well. Rheumatoid factor, a very commonly used serological test. We use it to diagnose rheumatoid arthritis, but as we've seen in the last few talks, it's not present in all our patients. Half of our patients can have a negative rheumatoid factor, but you have a high index of suspicion. It can be repeated, particularly in the first 2 years. It's not related. We don't correlate it with disease activity. It's useful in the diagnosis. This is the sensitivity and specificity. But if a patient has rheumatoid factor positive with a high titers, it's usually associated with extra-articular features as well as rheumatoid nodules. Anti-CC antibody is much more specific for rheumatoid arthritis compared to the rheumatoid factor. For us in rheumatology, it helps to identify a group of patients who are at risk of progressive disease, so we treat them early. So these are the patients that need to be referred to us rheumatology early, so we start them on disease-modifying drugs and maybe also biologic treatment. So if you don't have these indications, don't do the test, because you'll end up with a confused patient, a confused physician, and it will make the life of a rheumatologist difficult because we don't know how to interpret these tests. So going back to our case presentation, the first lady that I presented, the 22-year-old lady with symptoms worse in the morning, some muscle pain, no joint pain. Would you do any serological tests? Nope. Good. So I would only do a CBC, thyroid function test, and maybe a CK, but no need for rheumatology tests. Case 2, 45-year-old with joint pains worse in the morning. Would you do any serological tests, and which ones? Very good. You'll all be listening. Rheumatoid factor, ANA, and an anti-CCP antibody. And this 48-year-old gentleman with known rheumatoid arthritis who wants to stop methotrexate, are there any tests you would do that will help you to tell whether his disease is active? He's CCP positive already. The test is only going to diagnose. It cannot tell you whether you can stop the treatment. So I would only do his inflammatory markers and a DAS28 score, which is a disease activity index, to decide whether he needs to continue with treatment. But on the whole, if he's CC positive, he's always going to be CC positive, and we don't usually stop treatment in CCP positive. If they're in remission, we can reduce doses, but we never stop treatment. So to conclude, serological tests are helpful because they are helpful in the diagnostic conundrum. But if you don't have the right clinical context, do not order these tests. Thank you very much.